Low back pain, often called LBP, is a common complaint that affects up to two-thirds of adults at some point in their lives. It typically refers to pain located between the lower rib margins and the buttock creases, and may sometimes radiate into the legs. While the pain can be distressing, it's important to remember that LBP is a symptom, not a disease. There are many potential causes, ranging from muscle strains to more serious conditions. In most cases, the exact source of pain can't be pinpointed, and these are classified as nonspecific LBP. Understanding the nature of your pain is the first step toward effective management. Low back pain is incredibly prevalent worldwide. Studies show that nearly two-thirds of adults will experience it at some point. The economic impact is significant, with chronic cases leading to lost productivity, increased healthcare costs, and even disability payments. Despite its frequency, most cases are not linked to serious underlying diseases. Instead, they often result from minor injuries or degenerative changes in the spine. Recognizing how common and usually benign LBP is can help reduce unnecessary worry and guide more appropriate care. When evaluating low back pain, doctors often classify it into several categories. These include nonspecific LBP, LBP with radiculopathy or spinal stenosis, LBP referred from nonspinal sources, and LBP associated with specific spinal causes. This classification helps guide further assessment and management. A thorough medical history and physical exam are crucial, focusing on risk factors like osteoporosis, cancer, or previous imaging. Tests such as the straight leg raise and neuromuscular exams can help identify nerve involvement. This systematic approach ensures that serious conditions are not missed while avoiding unnecessary interventions. Most patients with acute low back pain improve significantly within the first 4 weeks, even without imaging. Routine imaging is not recommended unless the pain persists beyond 6 weeks despite medical management and physical therapy, or if there are signs suggesting a serious underlying condition. These conditions include cauda equina syndrome, malignancy, fracture, or infection. Imaging should be reserved for those with severe or progressive neurological deficits, or when a specific, serious cause is suspected. This approach helps avoid unnecessary tests and potential harm. Doctors look for certain red flags when assessing low back pain. These include a history of cancer, unexplained weight loss, fever, recent trauma, or neurological symptoms like leg weakness or bladder dysfunction. However, studies show that many red flags are not very specific, and most people with acute LBP have at least one red flag, even though serious conditions are rare. The most reliable red flags are a history of cancer and strong clinical suspicion. Careful evaluation helps avoid unnecessary imaging and interventions. The natural course of most acute low back pain is favorable. Studies show that the majority of patients experience significant improvement within 6 weeks, and by 12 months, average pain levels are low. Even in cases with nerve involvement, such as radiculopathy, symptoms often resolve on their own over weeks to months. Recurrences can happen, but most episodes are self-limiting. This knowledge supports a conservative approach in the early stages, focusing on symptom management rather than immediate imaging or invasive treatments. Disc herniation is a common finding in patients with low back pain, especially when nerve symptoms are present. Interestingly, many disc herniations shrink or even disappear over time without surgery. Studies have shown that most herniations regress within 8 weeks of symptom onset, and the largest herniations often show the most significant improvement. This spontaneous healing further supports a conservative approach, reserving imaging and invasive treatments for those who do not improve or who have severe symptoms. Imaging often reveals degenerative changes in the spine, such as disc height loss, bulging discs, or spondylolysis. These findings are common even in people without back pain and become more prevalent with age. While some changes, like Modic type 1, may be more closely associated with pain, most degenerative findings do not directly cause symptoms. It's important to interpret imaging results in the context of the patient's clinical picture, rather than assuming every abnormality is the source of pain. Modic changes are specific MRI findings that reflect changes in the vertebral end plates and adjacent bone marrow. Type 1 Modic changes, which show an edema pattern, are more likely to be associated with low back pain. However, even these changes can be found in people without symptoms. The presence of Modic changes should be considered alongside the patient's symptoms and other findings. Some studies suggest a possible link between low-grade infection and Modic changes, but more research is needed. Schmorl's nodes are another common finding on spinal imaging. These are small herniations of disc material into the vertebral body. Most Schmorl's nodes are asymptomatic, but when associated with bone edema, they may be linked to pain. Differentiating between symptomatic and asymptomatic findings is crucial to avoid unnecessary treatments. Imaging should always be interpreted in the context of the patient's symptoms and clinical history. Lumbar spinal stenosis is a narrowing of the spinal canal or foramina, often due to degenerative changes like facet joint arthritis or bulging discs. It can cause symptoms such as leg pain, numbness, or weakness, especially when walking. However, imaging findings of stenosis are common in people without symptoms. Diagnosis requires both characteristic symptoms and imaging confirmation. Conservative treatment is often effective, and surgery is reserved for severe or persistent cases. Facet joint changes, such as increased fluid or edema, can be seen on MRI and may be associated with instability or pain. However, it's difficult to definitively identify the facet joint as the source of pain based on imaging alone. Other findings, like spondylolysis or spondylolisthesis, are also frequently incidental and may not cause symptoms. Imaging abnormalities should be interpreted carefully to avoid overdiagnosis and unnecessary intervention. While imaging can be helpful in certain situations, it also carries risks. Unnecessary imaging increases healthcare costs and can lead to additional tests, referrals, and even invasive procedures that may not benefit the patient. Exposure to radiation from X-rays or CT scans is another concern, especially in younger patients. Furthermore, learning about incidental findings can cause anxiety and may actually worsen recovery by making patients overly cautious or fearful. Studies have shown that increased use of advanced imaging, such as MRI and CT, is associated with higher rates of spine surgery. However, many of these surgeries may not improve outcomes, especially when performed for findings that are not clearly linked to symptoms. Early imaging, particularly within the first month of acute low back pain, is linked to higher surgery rates and increased medical costs. This highlights the importance of careful patient selection for imaging. When imaging is necessary, MRI is usually the preferred method because it does not involve radiation and provides excellent detail of soft tissues and bone marrow. MRI is especially useful for distinguishing between benign and malignant fractures. X-rays are typically used for suspected fractures after trauma, while CT scans are best for detailed bone assessment. Each modality has its strengths and limitations, and the choice should be tailored to the clinical scenario. Radiography and CT scans expose patients to ionizing radiation, which can increase the risk of cancer over time. This is particularly important for young women, as the gonads are close to the lumbar spine and difficult to shield. MRI, on the other hand, does not use radiation and is safer for repeated imaging when necessary. The risks of radiation exposure should always be weighed against the potential benefits of the test. The first line of treatment for low back pain is non-pharmacological care. This includes self-management, exercise, education, and physical or psychological therapies. Complementary treatments like acupuncture, massage, and yoga may also help. Patients should be encouraged to stay active and avoid bed rest. Medications are considered only if non-drug therapies are ineffective, with non-steroidal anti-inflammatory drugs as the first option. Stronger medications or injections are reserved for severe or persistent cases. For patients with severe functional disabilities, persistent radicular symptoms, or refractory pain, referral for epidural steroid injections or surgical evaluation may be considered. Epidural injections can provide short-term relief, especially for acute radicular symptoms, but are less effective for chronic pain or severe stenosis. Surgery is reserved for those with significant functional impairment, progressive neurological deficits, or pain lasting more than 6 to 12 months despite conservative care. Surgery can provide faster pain relief for certain conditions, such as severe radicular pain or spinal stenosis, but long-term outcomes are often similar to conservative treatment. For most patients without serious conditions, surgery offers little additional benefit. Procedures like spinal fusion should be limited to those with instability or deformity. Radiofrequency denervation may help some patients with facet joint pain, but evidence is stronger for continuous rather than pulse techniques. Radiologists play a crucial role in supporting appropriate imaging decisions. They can help ensure that imaging is only performed when truly indicated and provide clear reports that distinguish between clinically significant and insignificant findings. By collaborating with referring clinicians, radiologists help prevent unnecessary tests and interventions, ultimately improving patient care and reducing healthcare costs. In summary, most cases of low back pain are self-limiting and do not require imaging. Routine imaging does not improve outcomes and may expose patients to unnecessary risks. Imaging should be reserved for those with severe or progressive neurological symptoms or suspicion of serious underlying conditions. A thorough history and physical exam are essential for guiding decisions. By following evidence-based guidelines, clinicians and patients can avoid unnecessary tests and focus on effective, conservative management.